histology sections. So this is a section between the forehead and temple in verified photo. Can you count the number of the fascia? It is possible, countless. So from the frontalis muscle lateral border in upper temple, numerous fascia extended temple areas. Actually, this is the muscle fascia covering the above the muscles or the right plane of the muscle or beneath the muscles. So it has been referred as the SNAS or superficial temporal fascia. So now we are doing to clarify the detailed anatomical feature of the fascia, including some other soft tissue layers. This is one of the results showing the detailed thickness of the soft tissues, including epidermis, dermis, more or less about 1 millimeters, and D1, so-called D1, or the dense subq or the loose subq, based on the area of the facial structure. This is only one result. So based on these ideas, we can also target the layers based on the different thickness topography, and it is very useful ideas in many clinical strategies. Once again, this is an ultrasonic examination on the lateral forehead areas. You can see the numerous layers, including epidermis and the other subcutaneous layers. Clearly, you can see the muscle layers, frontalis, but you can see the fascia covering the above the front muscles and beneath the muscles. So we will call this then the suprafrontalis or infrafrontalis fascia. This fascia extended to the temporal region, so it becomes the SNAS plane. So what is SNAS? I think this is not the special structures. So even in the illustration of this section, we will show them very simplified photos. You can see at the forward temporal junction areas, you can see that extending the frontalis muscle in upper temple, as you can see, numerous fascia extending to the temporal areas. And deep to the superficial fascia, there's another intermediate fascia structures. And then we can hit the deep temporal fascia. You know, deep temporal fascia continues from the periosteum of the frontal areas. So countless fascia structures occupied in the temporal areas. This is the real anatomy. So we should clarify these anatomical features. You know very well, we published one novel data last PRS journals. And also we had very many difficulties in persuading the reviewers. So generally, reviewers, they're all, strict, thinking of the opinion based on the previous publication. But we successfully published these papers. As you can see, superficial layer of the temporal fascia was now attached to the geometric arch areas. And instead of the attachment, it passed the geometric areas and huge real fascia, or becoming another very interesting fascia structures. This is the real nature of the superficial layer of the temporal fascia. Once again, from the scanning by the ultrasonography, you can see the anatomical structures, which are major, even in the orbicus oris muscles. And you can see the basic fascia structures, such as a deep layer of deep temporal fascia in blue, and red arrowhead indicating the SNAS plane. However, between them, clear, distinct fascia structures passing the geometric arch areas and cover the major as a fascia and extending to the perioral structures. So I think this is the thicker than the SNAS and located very superficial of the facial structures. Once again, frontalis has its own fascia. Rhizos muscle also has its own fascia. Even though the muscle thickness is very thin, but you can see that you can demonstrate fascia structures based on the muscle layers. This is the real or the nerve or the so should be a revised anatomical feature of the facial muscle. Okay, let's try to go on to the filler injection techniques based on the our data. And most of these papers has been supported by the German pharmaceutical company. So we had some papers for the greatest outcome or safety in terms of the filler injection techniques. You know, beforehand, whenever there are so many guidelines, actually this is an illustration by books. So many authors wanted to demonstrate their own techniques. As you can see, the needle techniques is proposed by our author, plastic surgeons. Anyway, there are so many guidelines, but we should know that the vascular structures, wherever this paper published in 2016, 17, something, with Loshman and Wiraman, and with my lab members, we published in the vasculature beforehand. So basic anatomical guideline is the most important. And in addition, there are another nerve structures passing the midline of the forehead. We name these vascular structures as the forehead midline vessels. As you can see, these vessels running in the midline of the forehead areas, but unfortunately, these vessels running in the subcutaneous layers, not on the wall, not deep to the muscles. So definitely, we can observe the artery and vein structures more than 60 or even in the 95% cases at the glandular release areas. So you should understand this vessel to prevent any vascular compromise. Let's move on to temple. Wherever temple is not simple, very complicated. So even though you can demonstrate some layer of the temple structures, but clinically, we should understand detailed fascial layers. So this is a dissection. I dissect the skin and try to show that smash plane, superficial temporal fascia with the vessels. And deep to smash, we can see the deep temporal fascia very well. And now I want to talk about these nerve branches. We name this as the superficial branch of the zygomatic temporal nerve. So it was published in 2023. Actually, this is a nerve structures not published before. And we found that even though this branch is very fine and traveling all the layers, including deep temporal, the superficial temporal, and dermis or the subcutaneous layers, and their territory is greater than the previous nerve branches, so-called zygomatic temporal nerve. So we name these as the superficial branches. So a few years before, we tried to perform the clinical trial, and we did the split method. And on one side, we inject the zygomatic temporal nerve branches using a conventional techniques, and the other side, we try to very superficial injection, nerve techniques, to estimate, evaluate the anesthetic effect. This is one of the research method, and you can see under the ultrasonography, you can see the needle tips just behind the orbital rim areas, deep to the muscles, just above the deep temporal fascia attachment site. Very simple, but depth is only 4 millimeters. Using a fine needle, we can inject a little volume of the anesthetic solution, and you can get very nice or equal effect compared to the conventional techniques. Painless, and they give the very nice anesthetic effect. In the minimally invasive procedures, because the pain sensation and touch sensation are almost same based on the conventional techniques. This is the anesthetic effect, as you can see, including hairline and temple and forehead temple junction, and the skin structures above the zygomatic bone, zygomatic arch areas. So when you get this anesthetic effect using very simple techniques, it is very useful in many clinical procedures, such as HIFU, thread lifting procedures, the laser treatment, even some injection techniques. You can do that. Where our temple is composed, minimum 13 layers, minimum 13, but already I mentioned, I think total temple layers up to more than 20 layers. And on top of this, as I showed before, deep temporal fascia, especially superficial layer, doesn't attach to gynoid arch. As you can see, passing the gynoid areas, and you can see naturally, partial herniation of the temporal fat pad is found only above the gynoid arch and bone areas. In Asian feature, it's a clearer and another percussion cases, but because we have a little bit wider face than the percussion, sometimes we can treat some laser treatment to reduce this fat compartment. You can get a little bit slimmer face, like me. Now I tried some other clinical trial to reduce the fat tissues and some toxin in the lower temporal upper masseter. It was fantastic, even though I would give some difficulty in masticating the food taking, but I'm really satisfied about that. You can try, you can check your patient status on the ultrasonography. This is the histology sections and ultrasonic examination of the cadaver specimen, and you can see clearly deep temporal fascia. The superficial layers does not attach into the gynoid arch and pass these areas and become the fascia covering the gynoid major muscles. So this is one of our trials. We are trying to inject the high G fly product, the lower temporal region above the gynoid arch, into the temporal fat pad areas. Remember, temporal fat pad is the safe, very safe areas without any vessels, without any nerve branches. Target in these layers, as you can see, my cannula on the cadaver specimen, and you can see the blue migration to the injection or during the injection, and naturally you can see the tanking effect of the deep temporal fascia. You are trying to focus on the deep temporal fascia. Yes, SMAS as well, same layers, and then finally you can get the very nice immediate result of the low facial lifting effect. So I name this as a filler lifting of the low face. Okay, let's move on to the fourth temple. This is one of the very nice papers with support by the lower fillers. So anatomical, roof and substance fan are continuous structures. So between them, there's not any anatomical border. Already we have shown these areas of the dissection, where roof and substance fan plays a role in protecting the temporal branch of the facial nerve. So this is the very, very thin structures, but numerous nerve twigs passing in this joint. So this is roof and substance fan. So it has improved these papers. So this is continuous structures between them, and between the lateral forehead and upper or anterior temporal region. So clearly we could observe that tunneling structures between them. So we are trying to inject forward temporal simultaneously using one entry point. So we set up the entry point as a singular point along the temporal line. Definitely it should be on the temporal line. So we inject the forehead as a deep orientation, and also we change direction for the temporal as superficial orientation into the interfacial space. But many doctors worry about how the penetration cases. So we also measure the penetration strength with Dr. Won-Lee and using a cadaver specimen, and we measure the penetrating force. As you can see, in SMAS, it was a 7.5. But in a deep temporal fascia, it's more than two times greater. in terms of the penetration force. We do not worry about the penetration. Normally, we insert the cannula, perpendicularly direction or oblique directions, so it's impossible to penetrate the temporal fascia. So we don't worry about it. So this is forehead. After the putting the cannula on forehead, is generally you can show that the injection phenomenon. So after shooting, you can see the backdrift phenomenon, and then you can see clearly the filler product. I think this is a very unifying of the lower fields. It has a very pure, materials. So you can see the granular shape, like a very, pretty some granules found under the ultrasound. This is a typical feature of the lower fields. And also, you move to the temporal areas into the interfacial space, and during the shooting, we can start the backdrift phenomenon up to the entry point. That's a very granular shape, more volatile of the lower fields. I think this is due to the purity of the water and some materials, what you were showing yesterday. So this is immediate after, or a few weeks later after clinical outcomes. You can show that the very smooth contour in the fourth temple. Or when you try to inject for the temple only, so use of the single point on the temporal line is much better and easier than the other entry point. You can use these techniques. Sometimes. So basically, it is a technique for targeting the oversaturated areas, but in many cases, superficial or deep augmentation of the injection can be done. Only one thing, the immersion point of the ophthalmic arteries is the most dangerous point in our face. So it should be avoided. But unfortunately, during the subclaviation techniques, sometimes you can hit these areas. So this is constantly, you can observe under the ultrasonography patient, even the volunteer, even the cataract specimen. This is very important structures of the forehead vessels. Like that. Textbook, we show that the guidelines to use the cannula, and when you stuck the tip of the cannula in the medial capital plane, and it should be injected along the periosteum of the wing areas. So please remember, this is a very dangerous point. Let's move on to the subgiant depression. So there are many trials in many doctors. How about the pure plane injection for the correction of subgiant depression? So we tried these techniques using the lower fluids. As you can see, this is superficial augmentation. So with the ultrasonography, you can show that the product will get the subcutaneous areas. And deep layers, so-called SNAS plane, injecting on these areas, but as you can see, we need much volume. Because sub-SNAS areas and below the gigantic artery areas, actually, that is the location of total gland and muscles. So above the tortidial muscle fascia, the product should be placed. So we need much volume. But we cannot guarantee the longevity. So this is ultrasonographic examinations. So you can see suprasNAS and subSNAS, or the subcutaneous injection, or the subportal muscle fascia injections. So consider the longevity. So we suggest that subcutaneous injection is enough. When you inject the deep plane, most of the product move into the buccal space areas. So if you want to make a volume in the buccal space, you can inject the subSNAS plane along gigantic arch. Naturally, it is migrating into the buccal space. So this is a dissection of the subgiant depression. So we have above the program and above the muscle, there are many crucial structures of passing such as product and transverse facial arteries, and many facial nerve branches. Look at the arterial border of the muscle. There is a buccal fat pad, main body. So natural product in this space move into the buccal space. So considering the longevity, you should think about some injection strategy. Let's move on to the mid face and low facial structures. You know, there are many muscle structures occupied in the mid face or low facial space. Despite the clinical importance, the muscle anatomy in the clinical field is not clearly determined. So, actually, my major, one of the facial anatomy, my major is the muscle anatomy and vascular anatomy and what the nerve anatomy. So now I will try to summarize the muscle anatomy, and you can see my papers in the futures. So this is the basic guideline for the literature proof or the total operation procedures. In this status, we should understand the anatomical features. So this is a micro-CT images from our volunteers, not the clinical volunteers. So we are clearly show that info all those structures. When you look at the micro-CT images, you can see the bone of the maxilla, and superficially you can see orbicularis ocular muscles, vertebra or the orbital portion. So now try to show that what is the retaining ligament? Retaining ligament is present or not? Or you know, because a few years ago, I always mentioned that retaining ligament kind of fake structures. Inferior, orbicularis retaining ligament is a kind of structures just provide the anchorage of the internal aspect of the orbicularis ocular muscle. That's all. But for the etiology factors, it can be, but beyond the retaining ligament structures, there are many kind of etiology factors in the formation of the teardrop or the major groove. So you can see my review paper. In this status, we have to understand the angular arterial vein. This is a paper using a superimposing the dissection result. As you can see, angular artery running medially and more superficially, and the angular vein running the deep structure, deep plane, and a little bit more laterally at the level of the teardrop areas. So generally, in the general practice for the correction of the teardrop, we should understand, we should be aware of the angular vein structures located deeply and along the medial frontal plane, and there is definitely angular vein structures. Let's move on to the lateral fold areas. You know them now. Lobator superior easy and lobator superior muscle, and giant minor and major passing the lateral fold areas. During the passage, you can see the direct insertion into dermis just under the lateral fold. This is natural, anatomical consideration for the formation of the lateral fold. From the micro-CT images, we can show, we can definitely demonstrate the muscle fibers inserting of the running patterns, and from these images, we can demonstrate that each muscle fiber inserting the dermis along the lateral fold. This is definitely very clear anatomical features. But on the upper lip areas, these muscle fibers pass to the lateral fold and cover the very superficial layer of the lips. From the LS area, from the LS, from the genital minor, was occupied with the very superficial layers above the orbicularis muscles. This paper was very nice, published by the Dr. Low and Professor Swan before. And when you look at this, toxin for the pressure of post-extreme lips, there will be the injection into these layers. Or after the NPS treatment, reversion, is due to by these muscle leads. So we can understand many clinical effects after this many clinical strengths. Let's move on to the labor fold. This is one of the excellent cases, and you can see there's some kind of vascular some problem or area. Very well, generally, facial artery running in a subcutaneous areas, not deep to the muscle. So this is my cases based on my many dissections. Clearly, about 70% cases, facial artery running subcutaneous areas. And also, for the later fold augmentation procedures, we have to know that danger joint. One is a furcation point of the superior arteries, and the other, exposed segment of the facial artery, just 15 millimeter lateral to the from the chiral point. 2 points should be avoided. So we suggest that our book. This is the improved techniques to set up the your entry point. It should be on the mouse corner areas or the modular point in each patient. Definitely is a safe entry point. Let's move on to the intraorbital space. Very well. Just lateral to the nose area, very complicated muscle layers. You can about 4 muscle structures occupied in these areas. And deep to the muscle, you can see vascular structures. So this is intraorbital space, very well. So intraorbital space, as you can see, yes, many doctors worry about the vascular structures, what is some fat tissues. As you can see, this space is many nerve branches entangled in this area. This is the most important structures than the other fat or vascular structures. So this is the facial nerve and intraorbital nerve branches. It's occupying these areas, and above it will be the location of deep medial cheek fat compartment, very well. And within the fat tissues, you can see the many intraorbital compartments. So this is a well-known story. I think better than the microphone. But we can observe the many variational status, as you can see from the intraorbital arteries, where the left side cover the whole nose, and also 100% they communicate with the facial arteries, and also they communicate with the ophthalmic arterial branches. When you hit these areas, contralateral or the ipsilateral, some necrosis of ala could be encountered. So when you think about the layers, from the skin, you can see there's some subcutaneous fat and lobate superior muscles, and deep to the muscle layers with the intraorbital space. Generally it is occupied by the fat tissue, DMGF, and then deep to the muscle and vascular joint is the location of nerve branches. This is natural features. So in every injection procedures, the middle tissue should be touched the bone. This is one of the another papers. It will be published soon. And it's a history section, you can see. So from the skin structures, you can see the numerous muscle layers. Already we demonstrated more than 10 years ago. And this is facial vein and facial artery running more medially along the natural fold. Actually, this is the upper part. And it is the 4 distinct layers based on muscles. And this is the intraorbital, low part of intraorbital areas. But what is that? Just the deep to the nose area. It has been called the periala or subala space. We name this as a subala space. Between them, between the low part of the intraorbital and the subala space, there's a deep distinct muscle attachment. There's a nasalis muscles. So when you inject in the low part, that's okay. But when you try to proceed more medially, you can feel some resistance. That is due to muscle layers. So clearly, we could demonstrate in this case. This is buccal space. At the lower face, generally buccal space has been used, the anatomical location in terms of the infectious pathway or some, some other, metastasis procedures. So the liver ultrasound, we can demonstrate clear the structures, including muscle layer something, and from the dissection, yes, this is the buccomandibular space around the mental foramen structures. Only one thing, mental component should be considered. But when you inject the deeply, we can get very nice wide volumization for the correction of the low facial contour. Well, for the masculine face, for example, this is the buccomandibular space, newly, dominated space in this field here. This is very important. Where are these supplemental arteries? Facial artery has two different branches. One is the facial portion, one is the cervical portion. This is cervical portion, running the submental gland areas and trying to reach to the submental space. This paper is in 2012. At that time, I did not notice that these branches passing the lower marginal mandible. At that time, I did not notice. This is paper photographs. Where some vessels from the submental artery crossing the mandible and supply subcutaneously the chin soft tissues, for example. But fortunately, this vessel crossed midline, not the midline, about 1 centimeters laterally. So generally, you can observe the pattern of the crossing joint. So when we follow the midline injection, we don't worry about any vascular compromise. However, last year there was some case report in Thailand resulting from tongue necrosis. Can you understand what happens in the case? I want to try and show answer. This is also paper published in 2012. Along the passage of submental arteries, the facial artery penetrate the myoid muscles to become the sublingual branch. So, sublingual branch in the oral cavity has two different origins. One is the lingual arteries and facial arteries. And you can demonstrate this in this, dissections. So this is a genial high muscle. This is a myoid muscle. So big vessels crossing penetrate the myoid muscle, supply as a lingual branch, supply the tongue. Definitely, it is the facial arteries. So in many cases, in most cases, facial arteries penetrate myoid muscle to become the sublingual branch. I think sublingual branch, about 80-90% of the sublingual branch come from the facial artery, not the lingual arteries. Already we have shown before. So when you think about the tongue necrosis, this is natural story, natural anatomical etiology passage. So we should follow the guidelines like that. And about the lips, where much abundant, vascular structures supplied in the upper lower structures. This is the general pattern of the vessels. And then normally, mucosa layer is the location of the labial arteries. But many anatomical variations can be found. Dry mucosa location was found in 13 cases. However, considering upper and lower lip prevalence, in upper lip dry mucosa location was found in 7% cases. But in lower lip, it was found in about 20% cases. Amazing. Where midline of the lower lip, we could observe the many variation of status like this. This is midline of lower lips. And in addition, in upper lip, vasculatures, we also published one papers with our Japanese colleagues, direct anastomosis between the arteries and vein structures. Frequently observed the upper lip areas. So in an illustration, now we always demonstrate this unique communicating pattern. As you can see, facial vein located in the superficial upper lips and facial labial arteries running the T plane, they communicate anastomotic pattern found. So when injecting the superior labial arteries, it can be the product move through the bed structures. Or when you inject the vein areas, it can be also drained with the arterial structures. Nobody knows that. This is the lip structures. Especially the lower lip inflammation, midline should be avoided during the procedures because there are so many variations in terms of the vascular location. So this is Dr. Joseph Kim's techniques. He published papers, and he follows our anatomical variations. Like that, please block the midline using some wooden stick and inject in the right and left side bilaterally, make some tubercle, and then massage. Can make a simple rule. This is the best way to prevent escape from the vascular locations. And this is my last message. So what's that? This is the new brand of the Samsung ultrasound machine, Evo Q10. Just released in store a few days ago. But before release of this product, we checked some image quality something. I found that this is one of the best devices, lower price than the others, and I'll show that some quality of images. This is giant major muscles, and you can see based on the layer structures, we can see clear, distinct layers can be observed in Samsung devices compared to the contaminated devices. And in addition, this forehead example. This is the Venix areas in the upper images. Even in the intraocular region, we can show that the images. As I know, Paragon Care handled the Samsung devices, but when you try to, introduce, use the ultrasound machine, I think this is one of the best devices for your practice. Where anatomy is anywhere, anytime, for everybody. Anatomy is not my property. Anatomy is not our school, information of our school property. I want to use them for everybody, every doctors, for your patient safety and the greatest outcomes. Thank you for your attention.